Welcome to the Practical Dermatology Podcast. This month, we have an interview with Dr. April Armstrong and the latest news from around dermatology. Now, here's Dr. Neal Bhatia.
Hi, this is Dr. Neal Bhatia. I'm Chief Medical Editor of Practical Dermatology, and this is another episode of Practical Dermatology Podcast. I am pleased to do it with my good friend, Dr. April Armstrong. April's probably the smartest person I know and the best dancer in the specialty, besides from many other things. She is also professor and chief of dermatology at UCLA. And April, I want to pick your brain on psoriasis because I know it's one of your favorite subjects, but talk a little bit about just some of the research you're currently involved in and where do you see things going from here?
Great. Well, thank you, Neal. And it's such a pleasure to be here with you today. So there are so many things to talk about. I would say currently our group is working on epidemiologic studies to better understand comorbidities that are associated with some of our inflammatory skin diseases. So furthering in on HS and atopic dermatitis and psoriasis, of course, in those areas, I think there's just so much more to be understood about the comorbidities that can be associated with these inflammatory skin diseases. We're also doing some independent studies looking at GLP-1 receptor agonists and their role in these different diseases and if they have any independent effects aside from weight loss, of course, in our patients and see how they could potentially help our patients suffering from these inflammatory diseases with regards to either neuroprotection or also independent effects on the skin disease itself.
It's nice to see the approach, not only looking at what's under the hood with the metabolic issues and everything else, but the other part is keeping diseases away, not just making them go away, which I think is also real important in the strategy. The other part of the equation too, like you said about GLPs, I laugh because everyone was worried about needles and all of the impact of biologics, and yet everyone and their brother is on a GLP-1 agonist now. So talk about where do you see that fitting into dermatology now that some of the news is out.
Yes, yeah, I think it's actually critical to dermatology. As we know, we take care of diseases such as HS and psoriasis, and we know epidemiologically these patients have higher weight compared to patients who don't have these skin diseases. So reducing their metabolic risk is really important with these new innovations in anti-obesity therapies. So I think there's a lot to be learned in this area.
And just real quick, I know we've talked about some of the drugs in development, the new oral 23, there's another interleukin 23 biologic, 17A and F inhibitor coming. What are your thoughts on some of these early data points with some of those treatments in research?
Yeah, I think it's really exciting. I think that the next wave is probably the oral realm, which we can talk about a little bit more. I think when we're looking at the biologics, I feel that the field has really, we've got it in terms of the right targets. And now it's about how can we deliver that efficacy with fewer shots and also thinking about in terms of how those biologics can be potentially incorporated earlier in the treatment journey.
And getting patients into the idea that, okay, maybe with shorter numbers of shots per year, or maybe with some better long-term safety data, we can get patients, to take pills every day, or at least think about rotating, their treatments, which I think would be great. I want to switch your gear just for a second on talking about what you've done. Now, you've done a lot of leadership work with the IPC, with National Psoriasis Foundation, so many international initiatives. What has been your passion? Where do you see your drive, and where does that leave you for what's next?
Yes, so I've done a lot of work with these wonderful organizations, and through this, I think you really highlighted to me the wonderful colleagues that I've worked with and how everyone works on a different piece of the larger puzzle. I think one of the things I recognize over time is that with these great innovations, getting those innovations to our patients is one of the most important aspects. So that is one piece I'm very passionate about and working to try to make it better for our patients. And number two is also just in terms of the larger picture. And also, Neal, you've had deep involvement with American Academy of Dermatology, really helping to advocate for our dermatologists with regards to our ability to really run our practices and making sure that we can continue to maintain the care and augment the care that we have for our patients in that regard. So the good fight on the Hill, but also in terms of making sure that we continue to define ourselves and educate ourselves with these new therapies, so we can continue to really lead everyone in these endeavors.
Yeah. You brought up the initiatives on Capitol Hill too, because every September we go to the legislative conference, and you and I represent California, and try to get our group to stump a little bit, which is great. Try to get Medicare back in line, as well as some of the funding for research, and kind of leads me to my next question too. As a chief of a department, and someone who's heavily involved in clinical research, I mean, what part of trials in our current state do you see things going well, and what would you like to see differently? What would you like to change if you could take the screwdriver and change a few things around?
I think if I can take the screwdriver and change a few things around, it would be allowing patients to really be a part of clinical trials who are otherwise living really far away. Most of our trials require patients to come into our offices, as you know, Neal, to be a part of the clinical trial. Yet I feel that many of our patients can benefit from being a part of these newer innovations, but transportation is a key barrier actually to them. So thinking about in the future how federated clinical trials, remote clinical trials can be done can really help really ensuring that these opportunities are given to everyone.
We say, because here we live near the inland empires of California and the desert, and patients who don't have access to care, and yet you wonder how many underserved patients there are, how many patients with large skin cancers that could be in a trial, or head to toe psoriasis or eczema who aren't getting treated. So it does make that component of access, at least from a remote aspect, or at least making them eligible to be a subject in a trial. It could be a lot better. So I think that's real important. The other part too, as an educator, I mean, you as the chief of the department, I was a program director. We both know what it's like to make sure our youth are being treated, if you will. You want to call them youth anymore, but I think we're facing a shortage of clinical researchers in the future. What do you see as far as trying to break that tide and bring more of our younger dermatologists into clinical trials?
Yeah, I think that's a great question. I think a part of it is just exposure to clinical trials during their training. I think many of our residents are very busy with their clinical responsibilities, so oftentimes they may not have the opportunity or the bandwidth to be involved in clinical trials at that time. But I do think exposure early on is really important, perhaps even before they become residents, for example, having some exposure would be very good. And I think afterwards, it's really about making sure that you are positioned actually in an area where you can actually recruit, because that is one of the key things I see. Younger faculty or derms who have just finished residency, where they're situated is actually very important with regards to the ability to recruit for these clinical trials. And just having an open mindset, to be honest. If you've never done it before and you want to try it out, I think just having an open mindset, take on the trial that you think that you have the right population to recruit for, as a just take on one and then see how you like it, and then can go from there.
Well said. And I think too that opening that door to the younger derms and make them a little bit more invigorated might give them a boost in their career, as we see all the changes in medicine too. Well, April, thanks. I'm glad to steal a few minutes from you. I don't know anyone who works harder than you do, so thank you for spending a few minutes with me to talk, and everything you've done for us, and I appreciate it.
Thank you for having me, Neal.
And now for the news. In our top story, Galderma's nemolizumab, which is branded as Nemluvio, was shown to have enduring impact in recent interim data from a long-term extension study in patients with atopic dermatitis. The Arcadia trial included more than 19,000 patients with moderate to severe atopic dermatitis. The extension study looked specifically at the ongoing efficacy and safety of Nemluvio. The research team for the study presented 2-year data during the recent Revolutionizing Atopic Dermatitis meeting, showing more than 85% of patients with atopic dermatitis achieving at least a 75% reduction in EASI-75 at 104 weeks. The study also reported significant reductions in itch severity, showing 70% of patients treated with Nemluvio achieving nearly itch-free or itch-free status. Study co-author Dr. Jonathan Silverberg, a professor of dermatology and director of clinical research at the George Washington University School of Medicine, told Practical Dermatology that these new long-term data reinforce nemolizumab's sustained impact on both itch and skin clearance in patients with moderate to severe atopic dermatitis. Dr. Silverberg added that this offers meaningful evidence of a targeted therapy that can provide durable relief, which he said was essential for improving everyday quality of life for patients. Galderma received FDA approval for Nemluvio for the treatment of patients 12 years and older with atopic dermatitis in December. It is approved in the U.S. for AD and prurigo nodularis. New research suggests strontium cream may be a promising therapeutic option for the management of pruritus and hidradenitis suppurativa. A paper in the Journal of Clinical and Aesthetic Dermatology reported results from a 50-person study where participants completed baseline surveys and then applied strontium cream to areas of HS-affected pruritus for a period of 1 week. The results showed a significant reduction in pruritus post-application, as well as significant reductions in itch scores compared to baseline. The study also reported that 84% of participants would recommend strontium cream to other HS patients. The authors called out strontium's ability to significantly reduce pruritus when added to a real-world treatment regimen, adding that strontium's multifaceted mechanisms, including the inhibition of nerve activity and reduction of inflammatory mediator release, suggest it could be beneficial in alleviating HS-related pruritus. And finally, in the latest edition of Practical Dermatology's Atopic Dermatitis Journal Club series, Drs. Lisa Swanson and Peter Leo talk about a recent study in which dupilumab was linked with a reduced risk of atopic march in pediatric patients with atopic dermatitis. Here is a portion of that discussion.
We know that atopic dermatitis is associated with an increased risk of the atopic triad diagnoses like allergies and asthma, and it's more than a triad these days. There's now EoE. And we also know that dupilumab is an approved treatment for some of these things, approved for asthma down to 6, approved for EoE down to age 1. And what we're learning more recently is that early initiation of dupilumab for the atopic dermatitis might actually thwart the atopic march. I was so excited when I read this article. Peter, what did you think? Were your eyes wide open, super jazzed?
100%. I mean, right, this is the dream. If we could, so obviously curing the disease would be amazing, but preventing it would be even better. And this is the potential to prevent comorbidities that we know affect so many patients and have such a huge impact. And with a medicine that we already use and is already approved. It's one thing to hear about in the future, we're going to understand these things. It's quite another for someone to say, hey, the thing that actually has been helping many of your patients might actually be doing more good. And frankly, it's refreshing to hear something good instead of, oh, it's also doing something terrible.